This is actually a work that Ghana did with support from USAID Advancing Nutrition, and it was actually done within the USAID zone of influence, and which is basically in the northern part of the country. So the results that I'll be showing, yes, we'll be having some of the data from national, but a lot of them will be zeroing in on the area in which this work was done. So we will briefly be looking at the overview. And the overview of this, we will look at mainly this work was actually a mixed method that was done using the available and published reports within these areas. And the data that was actually used was one of the Ghana micronutrients survey that was done, and I'm happy to report that the person who led it within the country is here with us, Prof. Afewa. And we'll also be talking about the findings of this mixed method, and we will look at what DHIMS-II is giving us, especially when it comes to anemia, and then we conclude. So this actually, we were trying to, the aim was actually to describe the burden of anemia, and was also actually to look at the various causes or factors associated with it. And one of the other things, it was actually to look at what are the interventions or programs that are actually going on within this zone of influence or within these population areas. And one of, as I've already mentioned, we use a mixed method to do this. We review literature. We also do some few key informant interviews in this area. So if you, in terms of method, as it has already been said, the micronutrient survey actually used two methods. It used the pooled capillary, and it also used venous blood samples. One of also data sources that was used in this was the malaria indicator survey in Ghana, which was actually a single drop capillary samples that was used. And in the DHIMS-II, actually this is where we have various methods, because this is actually happening at the facility level. And because of capacity, depending on the availability of the diagnostic equipment within that facility, various methods are being used. One of them, sometimes if they have any of the biological method to be used, they use the assessment in terms of severe anemia, the PALA method. They go into also use the hemoglobin meters, which is HemoQ basically, and sometimes they also use the test strips. And as this data shows that from the micronutrient survey, you can see within pregnant women, the national level anemia was about 42%, and children under 5, it was about 36%, and that of women within the reproductive age, non-pregnant, which was about 21% or 22%. And as you can see, the northern belts, you can see relatively have a higher prevalence of anemia, as was shown or found in the micronutrient survey. This is similar when you look at the malaria, which was actually done by microscopy. And you can see that the malaria prevalence could potentially cause the, and helminth infections here is very high, as we can see. So here, this is what I was saying. The malaria prevalence nationally was about 14%. And you can see the infections among children. And we think this could be a potential cause of the anemia, the high prevalence of anemia that we see, especially in children under 5 years of age. The genetic disorder in the micronutrients was actually looking at thalassemia, alpha thalassemia, and sickle cell disease. And as we know, alpha thalassemia, sickle cell diseases causes severe anemia. And we also know that sickle cell trait especially causes mild anemia. And we could actually find out that in this population group, especially alpha thalassemia under 5, it was basically about 30%, especially 31% nationally. And in the northern part, except Upper East region, the two northern regions, which is the northern region itself and that of the Upper West region, were actually having more than 30% of this prevalence. Okay. So we look at the iron deficiency. This data is still coming from the Ghana Micronutrient Survey. As you can see at the national level, you can see that vitamin A, folate, and then B12 deficiency are prevalent in the northern regions of Ghana as compared to the national level. And the higher prevalence of iron deficiency and iron deficiency anemia in children under 5 in the northern belt versus that of the national level. So you can see that these prevalences are very higher up there, and there's the need for us to focus more. So we now look at what is our DHIMS-II giving us within these regions. And this is very important, as Elena has just demonstrated. To do a comprehensive etiology, you can see the amount that it will cost. And I'm wondering even if you are able to do one, how many years it will take a country to mobilize resources again to repeat this. So there's the need to find another cheaper cost that can give us within these periods that we are still lobbying and mobilizing resources that we can use for programmatic decisions. So in Ghana, all public health facilities are actually enrolled onto DHIMS-II. And we have about 10,625 of these facilities nationwide. And we have private facilities, which is about 1,664 also on DHIMS-II. Then we are having some of our faith-based facilities. We have what we call the Christian Health Association of Ghana, CHAG. And we are also having some of the mining facility areas where they have the facilities there. So what we realize is that these facilities, a lot of them are the primary healthcare facilities, about 7,000 of them, of the public facilities, which we call CHIPS in Ghana. And it is actually at the lowest health facility level, the community, which is the health post. And all of them, as and when they provide services related to these indicators that we expect them to report, they are supposed to record this in their registers and report on that. The good thing is this, as I said, it will provide us a real access, especially at the program level, at the management level, to be able to know what is going on at the operational point, because they are expected to report this every month. And in some cases, we are now piloting some of this, what we call the electronic registers, e-tracker in Ghana, where each and every day they use their tablet, provide this data, and then when they sync in, it is aggregated at the national level. And I think that is one of the things that could also be a game changer as that. So the other issues that has to do with it is their capacity, especially nationwide, for this electronic form of data collection as such. So what data do we have in DHIMS-II when it comes to anemia? We call it in Ghana DHIMS-II, District Health Information Management System. We try to decentralize this to give the lower level that power to be able to do that. So data entry is done at the operational point, I mean a point where this service is provided. And it is actually at the facility level. So what we have is the service provision point like antenatal care, where all women who are registered, their HB at the point of registration are checked. And if the HB is checked, it also go ahead to also check on the malaria status of this woman. And they also, the services that they are provided, this has not been shown here, but some of the other things that we have there is also in vitamin A supplementation, and then the iron folic acid supplementation that the country is rolling as an intervention to reduce this anemia burden. Other available data we have in DHIMS-II is also an immunization data and some of the infections. And the last time I checked, as a country, we have more than 42 reporting forms, and all these forms at the reporting level can be aggregated, and you can look at it based on the particular kind of diseases. So if you are looking at an infectious diseases, there's a form that will have a look at it. The only issue is that it is not an individual record. It gives you an aggregate data. So if I'm having so much of anemia within a particular district or a particular CHIP zone, You can go and look at the other areas of reporting where they report like HIV, the other areas that they report like malaria, to see what is happening regarding these kind of diseases. And that you are able to tell whether at that it gives you an idea what is happening. As I said, it is not the same individual that we are tracking their record, but it gives you an aggregate at that operational level to see. And if you also look at the antenatal care service provision, what we also do is all these services expected to be recorded, the HIV, the sickle cell disease of this pregnant woman who has come, and the blood disorders, that's at the GCPD. And we also look at the feeding at that material moment to record on these ones. So these are actually the data that is being collected, especially at the facility level, and it is reported through DHIMS-II. So what did we see, or what did we find? We found that anemia, this is DHIS data, women who were seen for the first time at ANC, that is our registration, in the northern part of the Ghana, you could see it was about 47, and at 36, 42. And this remains similar across all, and you can see there has not been so much variation. And we are also seeing that the method of this diagnosis, as we have said, is uncertain, because depending on the capacity and what is available at that point, because you may go, especially when it comes to this hemoglobin meters, such as the hemocubes, where we are using the cuvettes, and sometimes they are consumables, and when it finishes, it is not there at that material moment. And a pregnant woman is attending an ANC a particular day, you can't say go and come back later. This has to be assessed. So sometimes they have various methods of assessing this. But you can still see that there has not been so much variation, especially in this kind of prevalence. And we are also of the view that this method of diagnosis, as I have said, is uncertain, and we have not actually observed change in this. So it is actually telling us what could be going on in this. So this is malaria, and we are also of the view, especially at facility level, we are of the view this finding suggests it could be overestimated, because a lot of the people, especially, it is not done for a healthy person, but people who come to the OPD where they have suspected complaints and they test for them. So it might be people who have already experiencing some signs from their various homes and come. So we think that these malaria cases, especially as reported in DHIS2, could be overestimated as compared to that of the population surveys that have been done. And we are also of the view that what we are getting is actually the diagnosis is similar across board, and this is something that we think that diagnosis of malaria at the facility level is something that is reliable, and we can rely on this, especially when it comes to the etiology. So we are concluding that DHIS2 is a valuable source of data for overall anemia programming. As we have demonstrated, we haven't seen so much changes variation between that one and the micronutrient survey that was done. And it is also very important, as Elena has just demonstrated or shown us here, the cost of doing this. And my experience with CDC in the past 7 years in Ghana is telling us that it takes so much time, and it is time resource, and it takes a lot of funds to be able to conduct this. And it's also a complementary data that can help us as we plan, as we mobilize resources to be able to do a comprehensive survey on etiology of anemia. And we have the potential to make good use of this. As I have indicated earlier, in Ghana, we are now enrolling the electronic registers. And we are also trying to now enroll what we call Lightwave Health Information Management System, which we call LIMS. This LIMS is specifically at the health centers and hospitals level, where it is served as an electronic document when women, when they come to ANC and they are attended to, it is used to be able to capture all their data. So when this unique IDs is being used, it's something that we can actually use to even now track a particular person from one point of service to the another point. For example, if that person goes to do HIV/AIDS test with that one unique ID, that unique ID can be used, and all these are integrated into one database at the Ministry of Health, Ghana Health Service, and this can actually be used to give us a comprehensive etiology of anemia in that regard. We are also thinking that there's a need, as the data review process provides feedback for district, this data can also be improved in quality, and it could also give us a reliable information that we can use for programming and for the intervention studies. I think that's all that we have. Thank you very much.